scale-up plan was we discussed this yesterday. So the user fees, here we are talking about there are no formal user fee for service provided by the CHW, by the way. So their service will be free of charge. Of course, free of charge, the community will not pay something. Though we need the community to support them in anyhow, whether, of course, even welcoming them and assisting them in it just in for them to work, creating a conducive environment for the CHWs to work. And the last component is the health system linkages. You will see the next slide will actually show how the community-based health services is linked to the general health system of the country. You see, for those who are not aware of our system, it is a pyramid-shaped kind of a health system where community-based health services is found at the bottom. Of course, where you also find the community themselves and the community health workers at the bottom. As you go up, you go to the level of village, ward level, district level. At all these levels, you will find health care facilities. So on the community level, of course, we have some dispensaries at the village level. At least from the village level. At the community level, you find the community health workers. But the nearby health facility will be the dispensary, which is also placed at the village level. And then as you go up, there is health center, district hospitals, regional level of hospitals, zonal hospitals, and national hospital at the top. And the community health workers link the community with the nearby health facility. In this case, we are talking of the dispensary and the health center. Of course, some areas, maybe even the district hospital may be closer to the community. So, but we are saying at the lower level, they will link the community to the nearest health facility for the continuity of the service. And yes, I am about to finish. So the roles and responsibilities are also included in the roadmap. Who will do what? And here we have considered the levels. Like the number one there, you can see the village health committee, which is found at the village level. This one is one of the structure of the public primary health care. So village health committee, it is responsible for participation during the selection. Of course, this committee oversees the selection and the nomination of the process of the community health workers. But again, to supervise the services, their services, their daily doing or daily activities are also overseen by this committee. Of course, we say administratively, they will be supervised by the village executive officers or mtaa executive officers, and technically by the health facility in charge. But this committee has also a role to oversee generally and report to these supervisors if anything they observe anything. But again, number two is the village nutrition committee. This is another committee also because they will be giving the nutritional kind of services. But this committee also will participate in overseeing the nutritional services being offered by this committee health workers at the village level. And also the social service committee. This is, of course, all these are the local government structures. So this committee also is responsible to participate in the overseeing social services in the community that are offered by the community health workers. At the world level, we have the WDC, you can see. This one, this body is responsible for, but as of now, they are responsible for receiving the application from the community health workers. Of course, those who wish to become community health workers, and then overseeing the process of selection, generally within their ward. So they approve the names of the selected. After the selection, then they again have the role to approve the names and they submit to the council level. And again, at the word community development officer, also mobilization of the communities to participate in the in these activities. So the word development, community development officers have this role of mobilizing this community, of course, in collaboration with other leaders, like VEO, as I said earlier. So there is primary healthcare committee. This is a multi-sector engagement in mobilization of technical and financial resources at, of course, at various level, and so could be at the regional, or could be at the regional, could be also at the council level, or down. So these are the structures that are also highlighted with the key roles and responsibilities in this roadmap. So I think here I will not use much of the time because we have already discussed these ones. But at least we can see, like when we are talking of leadership and governance, we already say it as a key investment area or action area. So here we are focusing on the formalization and strengthening governance and accountability coordination mechanisms, and for the community health at all levels, including the establishment of National Community Health Task Force, which also have subcommittees in it. So, I think I have already explained it. Even yesterday we discussed about this, and this is the structure we saw even yesterday, and it is the same structure. It is also found in the community health roadmap. But again, the financing, as I said, financing, there is a subcommittee working on it. Of course, proposing the best sustainable way to finance this program. And so they revise and they cost the operational guideline for community health and develop a comprehensive investment case. So there is a lot of work that is going on this, and this meeting also is part of this. The issues of financing, the best way to finance this program, and the sustainability of the program. The health workforce, I think we have already discussed it as well. So this to revise the community health workers training curriculum, I already said, and the service package as well. So moderator, of course, I'm giving sort of what we have already discussed it, but I am about to finish my presentation. The service delivery, we have also discussed this. The key issues here is to define the scope and operationalize the national comprehensive integrated service package. That also includes the curative, basic curative part of it. And also to strengthen the linkage between the community and the health facility. The health information system, as I said, there is a subcommittee that's working on this. There are a lot of activities that are going on, and they have actually proposed about it. I think the work is still going on to improve the system and to make it operational. The supply chain, as I said, there's also subcommittee working on this to propose how best the supply can be extended down to the community health workers. How these community health workers will get the supplies for their operational activities, and of course, as of now, they will be receiving the supplies from the nearby health facility. Of course, the facility that is supervising them, and where they also submit their reports. So another area is to the community engagement, as I said, from the identification and selection of these community health workers, even the supporting them, creating an friendly environment for the community health workers to work. So ours, as I said, it is a community-led kind of an identification or selection. Our role is just to supervise and to make sure that fairness is considered at all levels. And the opportunities for integration, as you can say, we have a lot of areas where we can integrate all the key action areas. We can work together, and yeah. So Let me go directly. We have this technical working group. Number two, service delivery. We have the primary health care and the technical advisory committee TAC for community health-based health services. Of course, as I said, we have this task force that is actually overseeing all these activities, and of which it replaced the technical advisory committee, by the way, because what we did is like we uplifted the technical advisory committee to a task force that is more engaging and that has more partners. And even the decision making is possible because the task force now is under the CMO, where of course the technical decisions can also be made. And these are some of the area key type of integrations and the key opportunities. I think I don't need to waste time. Most of you cannot even read, but this what I am presenting is available online. Anybody where you are, you can just read it from online. These are some kind of a milestone that we have gone through until we joined the community health roadmap. In yesterday presentation, if you noted, since 2014, we had this the guideline, and we established a community health workers program that were trained for 1 year in the training institutions. And then later on, at 2015, we had the National CHP Costed Strategic Plan as well. But later on, we realized that we need to review. And 2020, we reviewed it. We had another guideline, which changed from having the CHWs who are trained 1 year to a shorter training, and of course with some other challenges. Yesterday, I think you noticed in the presentation that there are other challenges like coordination and even the sustainability, the financing, even the ones who are trained were not willing to work at the community level because they had other options. Working in the health facility and the social welfare environment. So this was the reason why 2020 policy guideline was came out, and then at 2021 we had an operational guideline that we are currently reviewing it again to accommodate these few changes that we have made in this new program. So 2023 we joined this community roadmap, as I said. So these are some of the key actions and the timelines. I think I don't need to waste time. Otherwise, thank you so much. These are the partners who participated, and I acknowledge the contribution of UNICEF and the USAID at this end. Thank you so much. Moderator, as I said, my colleagues from UNICEF, USAID can also contribute if there is anything that or more clarification needed as well. But at this time, thank you so much. I'm done with the presentation.
May I request to clap for Yuda? Thank you. Just for the interest of time, we will continue with the Q&As after Zanzibar's World Kuhusu presentation. We are privileged to have Director of Preventive Services with us this morning, so it will be an honor for him, Dr. Ntuli, to come and his remarks. Our hands together as he approaches the podium. You're welcome, sir.
Thank you very much, Dr. Umma. It's a privilege for me to stand before you. And let me take this opportunity sincerely to thank each and every one of you for having made it to this very important activity. Well, we didn't attend the first sessions. We had some other commitments. Actually, we had already informed our minister to come and officiate this meeting, but it was a bit unfortunate that she was also called to go to Dodoma to attend some other commitments. So we have just arrived from Congo Brazzaville, where we had a very fierce campaign, but luckily we were able to win the election for the regional director for. So from the campaign, I've gotten a lot of experiences. I think maybe for my friend Richard, next time if you are maybe aspiring to contest for anything, please, you can invite me over to that. So, ladies and gentlemen, I'm very much delighted to be here today, and the topic or the issue at hand is something which is close to my heart. It's very close to my heart, and whenever I see the gathering of this kind discussing issues pertaining to primary healthcare, community healthcare system, I become very much excited. So today as well. From Yuda's presentation, maybe I was able to get some of the things which he highlighted, maybe somehow halfway through. But what I can say is that we are very much committed to this undertaking, and we are also looking forward to making sure that we come up with a very important deliverable as far as this activity is concerned. And it has taken us a decade of try and errors to arrive to what you are doing today. So my humble request is that let us be very serious with this activity and looking into the composition of the people in this room. This shows how serious as we are, and I'm sure we shall come up with a very, very good output. With regard to the resources, the government of tried to its level best to make sure that we solicit resources from different stakeholders. But I must mention that UNICEF, USAID, the Benjamin Mkapa, and some other partners, they have been key to that, especially coming up with the roadmap. But this year, while we were attending the World Health Assembly, we also had an opportunity to host the side event where we invited different stakeholders and they made a number of pledges. I remember one of the stakeholders who attended was the UNICEF. We had the Global Fund, USAID, and some other. And they pledged 19 million US dollars out of that side event. And that helped us to galvanize some of the resources which will help us to train the community healthcare workers. So as I was going through the program, I find there's one item that is prioritization. So I wanted just to maybe request you, all of you, that while we'll be prioritizing, let us make sure that we do not fall into a trap of having a disease-specific priorities. We need system thinking. We need system thinking. If we fall into the trap of having the disease-specific priorities, then we'll be going back into fragmentation of the healthcare system. And we cannot afford to do that. The reason why we are having the new integrated and coordinated healthcare system or community healthcare system is one we want to defragment. So fragmentation has been one of the challenges. We have seen some other countries who are coming up with a new community healthcare system, but they went back into fragmentation. You find, you look into their priorities, HIV, malaria, TB, everything is about that. So in the end, you won't be able to do any integration back to square one. So I would like to really present that caution, because then if we were not careful, our exercise might end up being futile. So we want to be very much careful. But I was happy that we are going to be having one plan, one budget, uh, one M&E, as well, one report. That is very important. As far as healthcare financing of this initiative, we have tried to solicit funds from different sources. So we need to harmonize. So having one plan, one budget, one M&E is key to harmonize the resources, to leverage on the resources which we have, and that should be part of the assignment. We shouldn't just focus on the service delivery. We should go beyond that one. The healthcare financing component is one of the very important components as far as this initiative is concerned. We all understand that the community healthcare system is a bedrock for universal coverage, and our universal coverage service index is still low. We have 43, far below the global average of 66. So the only vehicle to uplift our universal coverage service index are the community healthcare workers. So how do we do it? Is through the coordinated and integrated community healthcare system. So I would really want all of us to be very serious in this undertaking so that we can reach the promised land. And I'm happy that in this room or in this house we also have colleagues from AFF, very experienced with this type of exercises. The Africa CDC, I cannot thank you enough. But in the end, all what we want is to have very good deliverables as far as this exercise is concerned. But I also wanted to touch on something that apart from this one, I think Richard and I, we had a very good discussion 2 years ago while we were in Mombasa. And of course, Africa CDC also hosted the activity in Mombasa. But also we have had subsequent meetings discussing on how best we can have an investment case. The return on investment. You know, we need to have an advocacy tool so that when we present to politicians and other stakeholders, they should be able to buy in to what we are trying to present. So investment case is one of the very important thing. WHO have done so. So while we were attending the World Health Assembly and also the regional committee last week, so they have come up with the investment round. So they did the investment case. They did some costing analysis. So now they have the document with several interventions, costed interventions, which you can easily present to different stakeholders and they can pledge. So last week's alone, we were able to pledge close to 48 million US dollars. I know it's a tall order because we are supposed to actually raise funds up to 11 billion US dollars for the span of 3 years as an investment round. But for this one, in Tanzania, we also want that one. We need to cost all our interventions and represent to different stakeholders. And the good thing with AFF, Africa CDC, they have very good or they are rich in experiences from Zambia to Liberia, Ethiopia, Rwanda, and other countries. Not to forget Kenya as well. So I think we can use this platform to also try to work on some of the very important tools, advocacy tools that will enable us to sell ourselves to different stakeholders so that we can get their buy-in and also get more resources to implement this program. And that is doable. Well, what we need is just to set aside while we are doing the group or activity, we can assign one of the groups to work on that. And that is possible because we have rich experiences. We have already learned from different models what works, what doesn't work. So there's no need of us being afraid. Not to forget Zanzibar, I've already done a tremendous job. So I've been following up the program in Zanzibar, and I'm happy Dr. Fatma is here with us. They have done so. So we have so much, and we have, different models to learn from. It's up to us to see how do we leverage on what others are doing. Last but not least, just to register our sincere thanks to all of you. And from this composition is quite very promising. Anyone's being left behind, everyone is here. So it will be so absurd to find out that we haven't been able to meet expectation of this workshop. And why shouldn't we? We should be able to really make sure that we do justice to this workshop. And so that in the end, when we read the report from this workshop, then you should be able to also convince our superiors that our colleagues were able to do something out of this activity. Otherwise, I think I should also present apologies for my superiors who couldn't make it, but we had an intensive campaign in Congo Brazzaville, so it wasn't that it was very intense, and I can assure you that had it been you, then also would have fallen into the same path of being very exhausted and not being able to attend to this. But this is one of the very, very important activity. Although I won't also be able to stay with you for so long, because I'm also in the drafting team for the Tanzania Development Vision 2050. And one of the aspirations which we have put into that is having strong community healthcare systems. So my colleagues started the day before yesterday. I'll have to join because I'm the only expert who's making contribution in the social services, the health, the water, and the education. So you'll have also to bear with me. So I'll attend for 1.5 hours, and then I'll have to leave. But otherwise, we really appreciate and we recognize your contribution, and we look forward to having a fruitful and productive workshop. Asanteni sana.
Thank you, Dr. Natuli. Feeling very inspired. I think in my regional role for UNICEF, following the journey towards universal health coverage, if I can say there's one ingredient that is the most important into being successful, it's having strong government leadership. So I really recognize your strong vision, your strong commitment. I think we all feel that under your leadership, we can go far on this journey. So thank you again for the encouragement. I think it was very clear what the ask is, that we optimize this time together, that we really have that health system strengthening lens. And we think more holistically around how integrated service delivery can serve best the women and children of Tanzania. So thanks again. Let's put our hands together for Dr. Natuli for such inspiring words. All right. So, in terms of the schedule, we're going to continue with questions and answers. We thought it'd be best to get them out of the way before we lose track from Dr. Yuda's presentation. And then we'll have a tea break. And from there, we'll continue with the presentation from Zanzibar and question and answer. So I hope that's okay. Hope you've taken note from what was presented from mainland. And we can maybe take the first 5 hands, questions that you might have. Got Dr. Barnabas in the front. Again, I don't have my glasses. I'll put them on for the next round. Any hands in the back? We've got Richard as well. Okay, 1, 2. Looking for 3 more hands. Anyone? Can I not see you? All right, well, perhaps, okay, Emmanuel, is it? Okay, number 3. Shall we start with the first 3 questions? Maybe that might inspire more. All right, Dr. Barnabas, over to you.
Yeah, so good morning once again. Thank you for the presentation. I have 2 questions. But before I ask my question, I would like to say that I'm very impressed about the roadmap. I see it to be very motivational and inspiring, very straightforward, and also something actionable and doable. And I think I would like to commend you for that. And also commend you for, when I look at the most important words in the roadmap, I see integration. And you realize that yesterday when I did my presentation, one of the elements of African CDC vision is to integrate community health programs in the broader national health system. And this is playing very well in your roadmap. And I want to commend you for that. So you are aligned to the continental vision. Let's clap for you for that. Yes. So my question, one of the agent investment action you mentioned, you talk about expanded integrated community health service package. And then your intention is to define the scope. So I was wondering, why defining the scope? Does it mean that you don't have a defined scope of services for community health workers as at that time you were doing this? And then secondly, I saw another point where you talk about involvement and integration of community health expanded package, career path as well. The career path, I wanted you to expatiate more on what exactly you are looking at, and whether or not there's already some work that has been done in that direction. Because, like I said yesterday, Ghana, for instance, we have an experience when it comes to career path for community health workers. So if you can explain this for me. I want to understand, because you also said you wanted to expand the service coverage or service package for community health workers. Does this link up to the defining the scope as well? Is there any linkage? Because it looks like there are 2 areas you are looking at, are they different? So if you can explain that for me, thank you.
Thank you, moderator. I just wanted to also appreciate that from the words of Dr. Antuli, it's very energizing to be in this room planning for an accession plan within a national strategy that is already fitting in the vision. I think this is really the classic example of true institutionalization. And also to congratulate Dr. Ntuli. We have no doubt you guys are going to do it for us. And just remember that you're not only there as Tanzania, you are there as East Africa as well. Sindio, nashukuru sana, nashukuru. I'm very grateful that ministry is representing these priorities. Thank you, Mr. Thank you, the presenter. And when I read through the first 4 priorities, they seem to be well sequenced. I think revising service delivery packages informs training and also informs the curriculum. But I want to draw your attention, and I'm so grateful you people went to Uganda, that operationalizing a national community health program at scale requires a lot of forth and back. It's very complicated. You'll encounter a number of problems. But the only way you're going to survive through is when you have a team-based approach. And that can only be solved through a national task force. And I'm so grateful it's part of it. In my view, you may not need to do anything before securing this task force. Because it is your problem-solving platform. It's a place where government goes and consults the partners. It's a place where partners bring in their technical advice to the government. And I want to caution you that the national task force must be a national task force. Don't make it an exclusive club of partners bringing money on the table. This is a problem I've seen in many countries. And if you remember, Dr. Afya said the same thing in Mombasa. We confuse 2 things: coordinating resources and coordinating a national program. Those are different. If you want to bring Pathfinder, UNAIDS, WHO on the table, USAID, it's okay. But please make sure local actors must be on the national task force, including academia. Do you know why academia is important? Your future public health leaders must know what's going on. And I'm grateful you're adding research. They play a fundamental role, because this program you're rolling out is going to stay for more than 3 to 4 decades. I'm grateful it's already in the Vision 2050. So make sure it's all inclusive. Nazo here can hear us about the localization agenda. We have a localization agenda that must shape international aid. It talks about local participation of actors, of civil society, of researchers. So I pray that once you create that task force, let it be both reflective of our important partners, but also indigenous Tanzanian organization. Now, the second one.
Yes, and I just wanted to add that more and more for our global fora and global meetings, high-level partners meetings that we're having for the Community Health Delivery Partnership, we are making sure that we have representation from both government leadership, but also community leadership, and not as a side thing. We want to integrate the local voices more and more into the planning process and really work towards the bottom-up planning. So I think it's really heartening to see Chic has played a key role in elevating voices of CHWs in the Monrovia call to action that was cited by Africa CDC. We had about more than 40, almost 50 CHWs who contributed to the Monrovia call to action. And I think we need to do more of the effective engagement of local stakeholders, particularly community leadership as well. Thank you.
Thanks, Nazo. So I think, in my view, let's prioritize that. Secondly, I'm grateful that you want to include certain aspects of the service delivery package. Some countries have rolled out and have had to recall because there are certain aspects of service delivery that are missing. I think you're starting off quite well. So maybe the question would be, if you're to cost that priority of service delivery package, are you talking about recruiting a consultant? Are you talking about organizing a series of workshops? Because once you do that, then you enable USAID, you enable UNICEF, you enable key players to say, I can throw my money here. So when we get into our groups, that will be very critical. When it comes to training curriculum revision, I think this is straightforward. We usually have TWGs. I think there you just have some series of workshops to revise the document and have it approved. Training CHWs, I would also recommend that you define where you want to start from. We have a number 28,000. I don't quite believe that you can wake up in a month and enroll 28,000 CHWs. I don't quite. I think yesterday you presented a number of existing CHWs that are not trained. I would recommend that maybe through the group we define where do we want to start from, and maybe rethink our sort of projection we gave for the 5 years. I think it's very ambitious. We need to come up with a realistic target every year. How many CHWs are we truly going to train, given the training institution's capacity? And lastly, in terms of operational guidelines, I think I'm grateful that Dr. Anturi talked about the investment case. That is a strategic document, because as you roll out some of these things, the resource mobilization must be moving forward. So it's a document that we need. But also, as we said yesterday, we need to understand the existing resources in this country. You need to have, as government, visibility, so that when they tell you this province, you understand that it's Save the Children implementing some work there. They have the reach of this proportion of CHWs. We can rely on them to support us in this way. Resource mapping helps you to see how much you have. It's a much simpler exercise, very versatile. USAID has done it in some circles. Dr. Ono said we did it with HIV. You can do it for the system and understand who are the players, what are they having to offer, so that it shapes your decision making, especially as you embark on training. So resource mapping can precede developing of the investment case. That's my view. Thank you so much.
Sorry, I just wanted to add quickly that I think as a part of the workshop outputs, there are plans underway, and we saw Global Fund had a menu of activities that you can select technical assistance from. I think it would be very helpful as we think about the priorities to also indicate where there may be some plans to make a contribution or an opportunity based on the way TA is structured. Thank you.
Thanks, Richard and Nazo. I think that helps shape a bit of the work we have ahead of ourselves, developing the acceleration plans this afternoon. Okay, last question in the first round.
Thanks. As we will be in the group, I believe we'll be looking at the specific roadblocks in every system domain. I wonder on Tanzania mainland. So first, thanks and congratulations for the great job on developing the roadmap. I wonder if we could have a view of any dependencies across the different urgent priorities, any challenge across the different priorities, so that when we go in the group, we can take these into consideration.
Thank you. So, Dr. Yuda, you're in the hot seat. I took some notes to help respond to question prompts. The first one was from Dr. Barnabas around integrated service delivery, and just to tell us a bit more about where you've come, and is this something new, and where you're at.
Okay. Thank you so much, moderator and colleagues, for the nice questions and some are suggestions which I hope we will take even during the group work. Some of this, and thank you so much for acknowledging what we have done, and yes, and your support, of course. Yes. The first question from Barnabas was about yes, the integration, and yes, he said, why are we defining the scope? Does it mean that we did not have the scope of community health workers? And I will, of course, respond to this question together with the question about the expanding the service package. The scope, we had the scope of community health workers. Even the existing community health workers, they have their own scope. But, because we revised even the criteria for the one to be a community health worker, we uplifted a bit. The reason is that we have also expanded their scope. Earlier, we did not include the part of basic curative service, which is a sensitive part of it, by the way, because they will be providing some kind of more technical services to the community. So that is the reason why we really plan to redefine the scope and expand to accommodate the component of the basic curative service. And yes, the career path. You also asked about the career path. This is another card. Of course, as an individual, like any other community member or individual in the community, will wish to progress, to go further to another level. So that's why even in the community health workers program has an opportunity, being a Form 4 leaver in our system, also provides opportunities to go for a more higher level kind of service delivery, where they could also join the other courses in health or social welfare services. So that's why we also consider that. Of course, by the way, it's one of the requirements when you are establishing a cadre. You also have to think of what if this person wants to progress. Is there an opportunity for this person? So that's the opportunities that we provided, and we considered that one as a career path for them. It does not mean that they will become a community health worker with a degree level, no. But their career path is also considered moving to joining other professions like nursing, even the laboratory, social welfare, like that. Yes, I think I'm done with that. Thank you so much for acknowledging the existence of our task force. Yeah, by the way, it is operational and it is in place. And that's why even in my discussion, I also repeatedly said there is a subcommittee working on this, because the task force, of course, it is a bit high level decision making board. But under it, there are other subcommittees working on the very specific issues like human resource, where the training also is also included in that. The deployment process is also overseen by that specific subcommittee. That also report to the task force. And the task force is a combination of the people from the government and from the partners as well. The decision makers, by the way. But the subcommittee also, it is a mix-up of engagement with the partners, all the key stakeholders, basing on that thematic area. Like when you are talking of financing, you look for of course, the donors. They are part of the subject committee and the government side, from the government side. So that is how it is structured. And the way it is, because as I said, it was like a community-based technical advisory committee. that was there before was uplifted to that level of task force, so that we can, this body will be able to make decisions, and of course to facilitate and to accelerate the implementation of the program. That is the reason. And we had the last meeting of the task force. One of the discussion was that maybe we will also consider changing the name, because the task force is like something that is there for a short period. After completing the mission, maybe that body will be. So we are considering to change it and to make it to be a permanent kind of a structure that will be overseeing this implementation of this program as a whole. And yes, yes, I also agree that they will comment that we really need to do more of the engagement of the partners, local but also international, because our aim also is to mobilize the resources. Yes, there is also about the issue of costing, the priority areas. Yes, and the issue that the doctor, our director, Dr. Tool, has also talked about it. Maybe I will leave for Dr. Tuli to respond on this. And yes, so before that, let me finish my part, and then I will allow even my colleagues who are free to contribute to clarify more from UNICEF, USAID, and other partners. The training of CHWs, the enrollment plan. Let me talk about this. Yes, we have done. We have done a lot of the planning, the enrollment plan. How many will be enrolled to certain number of institutions? Like for now, we are starting with 53 training institutions. And we have already planned that the capacity base, because we did capacity assessment. So there are institutions that will receive 100 CHWs based on the facilities and the trainers. I mean the facilitators they have. So that is already done, and we have already planned it. And now we are at the stage where we can now even officiate in that training, so that the training will start. And the training will be done by batches. Of course, the way we organize is that like in our plan is that because we also need to train a big number of community health workers in a year. Like our target is about 28,000. So that is countrywide. But now we have just started with only 21 cancers, where the first batch will have more than 3,000 community health workers. And of course, in average, training institution will have about 90, 80 to 100 community health workers. That is first batch. So, and remember that in some, of course, we are looking for an opportunity that after 3 months, because after 3 months, these community health workers will go out for a field practice. Then, at that period, the training institution will enroll another batch. So we will have like 4 batches enrolled in a year. And with that plan, of course, we have at least for seeing that we will be able to train that number in a year. Of course, increasing the number of the training institutions as well. And thank you so much for that. And yes, let me give a mic to Director.
Thank you very much, Judas, and thank you very much, Richard, for very important questions. Maybe I wanted to add on what Judas said. So, as part of the National Task Force, the chair to the task force is the Chief Medical Officer, but she has deputized that to me, so I'm the chair. But in the meantime, we are also working on trying to elevate. This is a unit under the health section. It's a small unit. So Honorable Minister assigned us to write a concept so that we can have a full-fledged program. So I've been in contact with colleagues from Kenya because they have a similar arrangement to see how can we start that one. And that will happen very soon to have a full-fledged program. Because we have learned from Liberia, Zambia, and some other countries, having this one under the health promotion section, it doesn't work. So it will feel like, yeah, so we thought we need to come up with, because with the program, then you shall have different coordinators, you shall have people responsible for financial management, and to name a few. So we will be sharing with you anytime soon on how are we going to implement it. And secondly, when it comes to the composition of the National Task Force, it's quite a very diverse group. So we have people from non-state actors, from private sector, and from the government. And these people have been chosen very strategically so that they can have maximum input into that. But again, I do agree with you that one of the main activities as far as this task force is concerned is to mobilize resources. So we strategically actually chose people to make into the group, but some of the representatives are the community healthcare workers. We have two community healthcare workers. They represent others. And we wanted also to change the governance structure at the community level. Because initially, in the planning team at the healthcare facility level, at the dispensary level, it didn't include the community healthcare worker. So now, with the revision of the guidelines, the governance guidelines, we shall have one community healthcare worker who is residing where the facility is to represent others. So that the ideas, aspirations should also be reflected into comprehensive healthcare facility plans. Because if you miss the health facility plans and budget, then you won't be able to sustain anything in that regard. So you have to make sure they are part of that. So we have also taken care about that. There's another thing which I thought I should add. The ambitious targets, 28,000. So those 53 institutions which Yudas mentioned, it's just for few community healthcare workers. So in this regard, what we have agreed upon is to also expand to include private institutions based on the capacity assessment. And the reason is that we want to make sure that we arrive to that number as soon as possible. Because we have gotten some experiences in the past. If it takes long, then you might end up having a huge challenge in terms of implementation. So the implementation science tells us that we have to do it within 4 years. Yeah, if you don't, then you shall encounter another challenge. You know, I'm from implementation side. Have had number of failures and number of successes. So I can attest, if you go beyond 5 years, we lose. We have to make sure that we squeeze within 4 years. We should have 137 to 194 community healthcare workers. And that is possible. Because majority of partners, they were waiting to see if the government will start. So now we have already consulted our minister. So we shall hit the ground on 23rd. If all goes well, to start this September. And I've seen number of partners were asking us when, but now we have now UK aid, others coming. They wanted to see this is starting, and we are starting. So my humble request is to see to get support, and that work plan. And if we get support, then we shall surely be able to arrive to that number within shortest possible time. And the other thing is the research part. So we made sure that we embed implementation and research into this one. In 2017, we had the prime vendor system established in Tanzania. This is a public-private partnership arrangement where you pre-qualify the private vendors to support the medical stores department whenever there is stock out of health commodities. So when we started, we forgot the research component. We struggled a lot. Up until when we had two colleagues that said we must have the research. And from there, the community funds, the directors facility financing, in whatever initiative which we are starting in the country, we make sure that we embed research. So as this one. Because it will inform us where we can adjust. You know, sometimes these things might look rosy right now. And then later you realize that you forgot one of the very important things. And one of the researches which we have strongly recommended is an implementation research, but looking into fidelity of implementation, FOI. So we also engage some research institutions, including the National Institute of Medical Research, universities. They will be part of this conversation. So with that team, surely we won't be able to miss anything. And the good thing, again, within the department, we have a very vibrant research team as well. And the Director of Preventive Services is the one which is coordinating all health researches in this country. So we took advantage of that to make sure that we do not miss into this program. The scope, yes, we had to change the scope. Initially, it was purely health promotion and prevention, looking into primary prevention and secondary prevention. Now we have gone into the basic curative services. And under the basic curative services also we selected some few interventions because we do not want to be too much ambitious so that it might backfire. So we chose some. So we started with malaria and diabetes. With HIV, we said, okay, we wait a little bit. Waiting for what the research will inform us. Because if you are not smart enough, then you might end up ruining the entire program. So we want to use a stepwise approach. But evidence-based. It shouldn't be just we start. No, we want to be a bit different. We want to complement this one. That's why we have to elevate it into the program. Because the civil servant in the health sector in the country, we have a total of 120,000. And this is going to be 130,000. So it's completely different, and also it's a huge undertaking. We want to make sure that But also, we made sure that we align with the regional and international guidelines. So we have from Africa Union the new public health order and the health strategy, which ends in 2030, but also the health workforce charter. We also made sure that we take into account all these key documents, but also aligning into the regional and international ambitions. Otherwise, I think the questions which were asked were quite very pertinent, and I agree with you that we should use a team-based approach. So the team approach surely to take us to where we want it to go. But as I cautioned earlier on, let us not fall into the trap of disease. Because we have gotten to where we are right now, because people are thinking so much on disease and they forgot the system. System thinking is highly needed. That's why we grouped the functions into three main areas: the health, the social welfare, and the nutrition. So the health part also divided into promotion, prevention, and the curative. The social welfare as well, and nutrition, trying to address all these key important issues. But also, we took care of the cross-cutting issue, like the climate, so that we can have a climate resilience system. Also, getting these ones to support us, because with all the big outbreaks which we have had in the past, like the COVID, they did a tremendous job. The Marburg virus disease, they did a tremendous job. So now we are also engaging them in preparedness for the mpox. Should it erupt, they should be there as well. We want that type of the team, not the team of community health care workers who are specializing in malaria intervention. We don't want that one completely. We want someone who can deal with different diseases, but it has what it takes, all the basics of dealing with different types, both infectious and non-infectious diseases. But also knows the system. The event-based surveillance, we want them in the surveillance of diseases. And we want them in reporting some of the key events at the community level. But at the same time, we are very careful not to make them overwhelmed or to end up into burnout. They shouldn't go that. That's why we need research with us to carefully be able to detect and also identify some of the things which might be of negative consequences to the community care workers. So I thought I should contribute on that, but the questions which were asked were quite very pertinent. But I think one of the things also we should discuss, how are we going to make sure that they comprehend the knowledge they have gotten for 3 months. So there are some of the colleagues who thought maybe we should have distance learning, part of helping them to refresh. So I think we need to think right now before we hit the ground, because when they start, then they need to remain knowledgeable. So how do we ensure that? So that they do not decline in terms of the knowledge which they received for 3 months. So those are the things we should think over. And we have the facility in place in Morogoro for distance learning. Can we exploit on that? Can we leverage on the existing facility to make sure that these people, they retain the knowledge that I've received throughout? Because these diseases and systems evolves all the time. How do we make sure they retain and they stay up to date? Those are the things we also need to think, especially the group of 130,000. You really need to craft a system that you are not leaving no one behind. Asante.
Yesterday, during my opening remarks, I said, in the region, Tanzania is trailblazing. And I would say that again after hearing the presentation and the remarks from Dr. Natuli, Yuda. Really, there's been not only systems thinking, but I find a lot of strategic thinking, some difficult choices, fueled by an appetite to continue to learn and improve and be evidence-based. It was really quite impressive to hear the foundations you've built, the strong vision, the strong priorities, and the progress you've made in this last year under a short amount of time. I think it's really quite commendable. So just one more round of applause for our presenters. So I think throughout the questions and the responses, we've got quite a few clues on things we need to keep in mind as we go into deeper discussions this afternoon for the work plan. And if there's more questions, I would encourage that these come out in the different task force subcommittees. And with that, I would then like to invite everybody to have some tea, some well-deserved tea, and that we meet back in 30 minutes at noon to hear from Zanzibar. Is that okay with everyone? Oh, okay. One comment. Is that Pascal? Okay. You can have my. Right. Just know you.
Thanks so much. And this is only to say kudos to the team, the government colleagues, very energetic, starting from Dr. Tuli, our new colleague Norman, and very, very energetic colleagues, Dr. Meshak and Yuda. So, very quickly to top up to the question that was asked by Barnabas. Yes, for the scope, we had a good lesson when we went to Liberia, learning from the symposium on how the CHWs are working globally. So we came back to country and advised our colleagues on how we can structure the work of our CHWs. In Swahili, they call serikali sikivu. So very welcoming, and this is the reason with this change, especially welcoming the basic curative services. This is something that we've been looking for, and we're happy to work with the governments to make sure that we accelerate this moving forward. And for the career progression, very quickly, in June we had learning exchange visit to Uganda with our government colleagues from PRH, Ministry of Health and Community Development. We learned a lot. And one of the questions that was asked by our colleagues on how we can move on with career progression in our country, and the response that we got was a kind of very different one, but I would like to say that for our approach that we are working with the governments, I think that will be a little bit different. And of course, one of the colleagues that we discussed with is the Director of Preventive Services, who actually before worked with the CDC Africa. I think you know that guy. So if you give me 2 minutes, just to welcome my colleague here, to say how our approach is. And this is our
USAID funded colleague with country lead for uh, local health systems, strengthening sustainability, working with ABT Associates, just to share a little bit of our approach on how we are moving with our career progression.
Okay, thank you. I'm Dr. Kesale from USAID HSS. And we do career progression of the SHW. And then at the beginning, we were planning to do like what Dr. Barnabas, I think, was saying, that moving to other colors and so forth. And from Uganda, and then we learned that, okay, we have to contextualize also and be realistic to career progression, because in Africa also it has some of the risk and impact if you build from what we do. So in here, what we have done is just to define career progression that resolves movement from where the community health worker is to the next step. Now, the next step can be within community health systems or to other administrative systems. For instance, the last 2 weeks we were in Mbeya doing assessment of supervision of community health workers. And we, USAID and the government colleagues from the MOH and the POLAG also, we learned there that, okay, the CHW themselves, some of them, they perceive that, okay, they want to move to be nurses and so forth. Others, they want to be within the community health system. And then in the operational guideline that we are reviewing currently, we have put the peer leader of the CHW, in which the CHW will be moving from just being a normal CHW to the next level, which is the leader of the colleagues. And then that also is one of the career progression opportunity that we put. Thank you for the matter of time.
Thank you for that. No, career pathways is really a hot topic in the region. We're seeing a lot of movement on this. I think if there's more discussion and more insights, maybe there's a small group who can meet at tea to discuss a bit further. I've definitely got some examples from the region as well. So I won't keep you any longer for your tea break. And if we could meet back here at 5 after 12. All right, thanks everyone. Asante sana. I'm going to be fired as moderator. I'm keeping people from tea. again, the Zanzibar priorities, and we'll have time for question and answer afterwards, so please take good note. And let's see if the system is up and ready.
until 2025 to decrease for neonatal for under 5 for maternal rate and neonatal mortality, as well as prevalence of child stunting and maternal mortality rate. Like you see, we have in a high peak, but nowadays see that the peak are slowly decrease. And our vision for the community healthy is a healthy Zanzibar population with reliable, accessible, and equitable, preventive, and curative healthy care services. These are our vision for community healthy, and we have a policy, environment. There are many policy like Zanzibar Health Policy and Zanzibar Essential Health Care Package. We have a transition plan for national community healthy program, and also like Zanzibar Health Policy for this community and Zanzibar Essential Health Care Package. One, we have a for us transition plan for national community healthy complete their program until complete their and also like Zanzibar Health Policy for this community and Zanzibar Essential Health Care Package. One, we have a for us transition plan for national community healthy healthy in Zanzibar, as well as to have a deployment and a scale up of community healthy volunteer in an integrated, sustainable, and coordinated manner. Another one is a revitalization of Shehia Health Custodian Committee. We have the healthy volunteer custodian committee that are found in an integrated, sustainable, and coordinated manner. Community healthy information. Another one is a revitalization of healthy Shehia Health Custodian Reporting Committee data. We have the healthy volunteer committee that are found in an integrated, sustainable, and coordinated manner. Community healthy information. Another one is the revitalization of healthy Shehia Health Custodian Reporting Committee data. We have the healthy volunteer committee that are found in an integrated, sustainable, and coordinated manner. Community healthy information. Another one is the revitalization of healthy Shehia Health Custodian Reporting Committee data. We have the healthy volunteer committee that are found in an integrated, sustainable, and coordinated manner. Community healthy information. Another one is the revitalization of healthy Shehia Health Custodian Reporting Committee data. We have the healthy volunteer committee that are found in an integrated, sustainable, and coordinated manner. Community healthy information. Another one is the revitalization of healthy Shehia Health Custodian Reporting Committee data. We have the healthy volunteer committee that are found in an integrated, sustainable, and coordinated manner. Community healthy information. Another one is the revitalization of healthy Shehia Health Custodian Reporting Committee data. We have the healthy volunteer committee that are found in an integrated, sustainable, and coordinated manner. Community healthy information. Another one is the revitalization of healthy